Good morning, my name is Brunetta Guaragni and I'm a neonatologist from Italy, and I will talk about neonatal cranial POCUS. The International Evidence-Based Guidelines on Point-of-Care Ultrasound for Critically Ill Neonates, issued by the POCUS Working Group of the ASST, suggest the use of cranial ultrasound to detect cerebral blood flow changes, germinal matrix and intraventricular hemorrhage, and cerebral midline shift. Cranial POCUS has been included in the Crashing Neonate Ultrasound Protocol to assess intracranial hemorrhage. The Crashing Neonate Ultrasound Protocol is focused on the evaluation of 4 vital organs: lung, heart, brain, and abdomen, most often compromised in the unstable neonate. Cranial POCUS enables the diagnosis of intraventricular, parenchymal, or large cerebellar hemorrhage that may present as a catastrophic event with apnea, bradycardia, hypotension, metabolic acidosis, and rapidly falling hematocrit or even seizures. We perform cranial ultrasound mainly with a 5 to 10 Hz curve transducer. We can also use 10 to 20 Hz linear transducers to visualize more superficial structures. Cranial ultrasound is done through the anterior fontanelle. The mastoid, temporal, and posterior fontanelle views are supplementary. To scan the coronal planes, the transducer is positioned in the middle of the anterior fontanelle with the marker on the probe turned to the right side of the baby. The left side of the brain will be projected on the right side of the monitor, and the right side of the brain on the left side of the monitor. The probe is then angled forwards and backwards to scan the brain. Here we can see the 6 coronal view. The first one at the level of the frontal lobes, the second one at the level of the frontal horns of the lateral ventricles, the third one at the level of the foramina of Monro and third ventricle, the fourth one at the level of the bodies of the lateral ventricles, the fifth one at the level of the trigones of the lateral ventricles, and the last one, the sixth one, at the level of the occipital lobes. Then, to scan the sagittal planes, the marker on the probe is pointing towards the baby's nose. So the anterior part of the brain will be projected on the left side of the monitor. The probe needs to be angled to the right and to the left to scan out to the sylvian fissures and insular area. These pictures are taken from a premature baby, and those ones are taken from a term baby. This is the mid-sagittal view. We can see the corpus callosum, cavum septum pellucidum, third ventricle, fourth ventricle, cerebellar vermis. Those are the second and fourth parasagittal views. We can see the ventricle, the frontal, occipital and temporal horns of the lateral ventricle, and the ipsilateral choroid plexus. And here the first and fifth parasagittal views at the level of the sylvian fissures and insular area. Cranial POCUS can detect germinal matrix and intraventricular hemorrhage, but it can also grade it and monitor its evolution. Germinal matrix intraventricular hemorrhage is one of the most common ultrasound findings in NICU. Global incidence is up to 38% in premature infants less than 28 weeks gestational age. It occurs in the highly vascular but also stress-sensitive germinal matrix, which is located in the caudothalamic groove. That is a subependymal region between the caudate nucleus and the thalamus. The germinal matrix is mature by 34 weeks gestational age. That's why hemorrhage becomes very unlikely after this age. And most bleedings occur in the first week of age. Here we have got two classifications, the Papil's one and the Volpi's one, and the one we use is the Volpi's one. Grade 1, the bleeding is confined at the germinal matrix or occupying less than 10% of the ventricle, and it's the bright spot that you can see here. Grade 2, the bleeding is occupying between the 10% and 50% of the ventricle. The grade 3, the bleeding is occupying more than 50% of the ventricle and causing its enlargement. A separate notation goes with the parenchymal hemorrhagic infarction, that is the hyperechogenic area around the ventricle over here. Why it is a separate notation? Because it can occur with any grade of intraventricular hemorrhage. So what happened few weeks, days after the bleeding? Parenchymal necrosis can occur and it can evolve in a porencephalic cyst. This is a parenchymal hemorrhagic infarction in the territory of the caudate vein involving in a small porencephalic cyst. And this is a parenchymal hemorrhagic infarction in the territory of the terminal vein, involving a much bigger area. This is not the time to talk about neurodevelopmental outcomes, but it's quite understandable that the consequences in this scenario will be more serious. Newborns with severe intraventricular hemorrhage have up to 50% risk of developing post-hemorrhagic ventriculomegaly due to impairment in either the production or reabsorption process of cerebrospinal fluid. And if the drainage is impaired, the condition is called obstructive hydrocephalus. So what we need to do to see if we need to seek for neurosurgical advice. We need to measure the ventricles. Standard measurement include the ventricular index, that is the distance between the falx and the lateral wall of the anterior horn of the lateral ventricle, the anterior horn width, that is the maximum diagonal width of the anterior horn, and this measurement needs to be taken in the third coronal view at the level of the third ventricle. Thalamus-occipital distance is the distance between the outermost part of the thalamus at this junction with the choroid plexus to the outermost part of the occipital horn of the lateral ventricle. Then the ventricular index needs to be plotted on the Levin's chart according to the gestational age. And the result greater than 97 centile suggests us to seek for neurosurgical advice. The anterior horn width larger than 6 mm is considered abnormal. The size of the anterior horn of the lateral ventricle does not vary along with the gestational age, with the normal size ranging from 1 and 3 mm. And those are the reference values for the thalamus-occipital distance. This distance needs to be followed up over time to check for any enlargement of the occipital region of the ventricle. Cerebral focus can be used to detect cerebral blood flow changes. Doppler imaging of the anterior cerebral artery and middle cerebral artery is done through the anterior fontanel in the sagittal plane. We measure resistive index, peak systolic velocity minus lowest diastolic velocity divided by peak systolic velocity. Normal range is between 0.65 and 0.9. The resistive index is increased in PDA, intraventricular hemorrhage, periventricular leukomalacia, hydrocephalus, pneumothorax, low arterial carbon dioxide, and is decreased in hypoxic ischemic encephalopathy, vascular malformation, and decreased cardiac output. Is cranial ultrasound just for radiologists? Neonatal providers can be trained to perform cranial ultrasound. In this observational study, cranial focus image acquisition improved significantly following care team training, which enable neonatal providers to diagnose intraventricular hemorrhage at the bedside. Thank you for your attention. I would like to mention Dr. Cesare Zambelloni. He is the doctor who taught us a great deal of what we know on cranial ultrasound.